Everyone. Thank you very much for joining us today. My name is Raquel Duarte. I'm a pulmonologist and a professor of epidemiology and public health at the University of Porto. Within UNITE4TB, I lead the work package 11, which is responsible for communication and dissemination. And that is why it is a particular pleasure to open this webinar, as it fits directly within our health literacy and outreach activities. UNITE4TB is an international project bringing together 30 partners from 13 countries with a clear and ambitious goal to set a new standard for anti-tuberculosis regimen development. The project aims to upgrade the current clinical trial methodology and to increase the efficiency with which new regimens are developed and delivered, ensuring that innovation reaches people faster with strong scientific evidence base and real world impact. In that context, discussing artificial intelligence is not just about technology, it is about quality, about trust, transparency, bias, and accountability. AI can be a powerful enabler in research, clinical practice, and communication, but it also raises important questions we must address with critical thinking and shared responsibility. It is my great pleasure to introduce Professor Lisbela Lopes, a professor of journalism at the University of Minho, with whom we have co-organized this webinar. So without further delay, I will now hand over to Professor Lisbela Lopes, who will introduce the session. Lisbela, over to you.
Thank you, Raquel. Hello, my name is Lisbela Lopes. Welcome to this webinar. Welcome, Professor Heidi Mertes. Thank you. Welcome, Professor Amparo, Alonso, Betanços. Ricardo Batista Leite will not be with us today. This webinar will be moderated by Professor Paulo Nuno Vicente. Paulo Nuno Vicente is a professor at the University Nova in Portugal, and he is a specialist in AI. Paulo Nuno, please.
Thank you so much, Lisbela. So good morning, everyone, and a very warm welcome to today's webinar. So it is really a pleasure to have you all with us, both our audience and our distinguished speakers. So thank you so much for joining us. Let me, of course, begin by briefly introducing our esteemed speakers, and I will start with Dr. Amparo Alonso Betanços. So she's a professor at the University of La Coruña, affiliated with CITIC, and coordinator of the Lydia Research Group. She's a leading expert in artificial intelligence with an extensive experience in European and industry-funded also research projects. We have also the pleasure to have with us Dr. Heidi Mertes, an associated professor of medical ethics at Ghent University and a founding member of both the Mathematica Consortium and the Bioethics Institute Ghent. And her research focuses on the ethical implication of biomedical innovation, particularly in reproductive medicine, genetics, and embryonic stem cell research. As my colleague Lisbela was mentioning, we also have, or would have with us, Ricardo Batista Leite, a medical doctor and CEO of Health AI, the global agency for responsible AI in health. Unfortunately, we can have Ricardo Batista Leite is unable to join us live, but we will of course start. We have the presentations both by Dr. Amparo and Heidi Mertes. So regarding today's format, so we do have, I was mentioning, two presentations. We will start by Amparo Alonso Betanços and following by Heidi Mertes, then so that everyone can prepare, and in the meantime, of course, share your questions. So we will have, I will engage with in talking with both Amparo and Heidi. So we have some questions prepared, but nevertheless, please, you will have the proper time. I would say approximately 10 minutes in the end to share your questions and interpellations, whatever that you want to share, and engage directly in conversation with both Amparo Alonso Betanços and Heidi Mertes. So this being said, with no further ado, we can start by the presentation by Amparo Alonso Betanços. I will, of course, would like to stress we are deeply grateful for our speakers to be with us today and for your generous contribution to this discussion. So, as I was saying, Amparo, Alonso, the floor is yours, as we used to say. So, thank you so much.
Okay. Let's see if I can do it. Thank you very much for inviting me. Thank you, Paolo, for the introduction to talk about artificial intelligence in health. And the first thing to say is that this is one of the most richest in data areas for artificial intelligence. However, decision-making is still very problematic because most of the decisions need to be made with partial data, noise, time restrictions, and the consequences are not possible to reverse most of the time. And we also have a context in Europe, at least, which is a shortage of personnel, increasing costs, age population, and the diagnosis is more and more complex. So I think that artificial intelligence comes to be a necessity and not a luxury in this context. Although medicine has been one of the classical areas of application of AI since the beginning, it's on the last years that we can see a lot of changes as the number of databases that we have, the application of generative AI, the increasing number of medical devices, and a wave of large-scale functional medical models. I think that as an indicator, we can use the 4 Nobel Prizes that were awarded to AI in 2024. So in these times, AI is already a reality and has an impact very strong in several areas, mainly in medical image. So it affects or it helps to decision-making, better say, in dermatology, in radiology, it's in clinical decision support, drug discovery, etc. And one of the latest areas also is the synthetic data generation that I think is important because it allows us for a better identification of social factors influencing health, helps us with models that preserve privacy, and even allows for the simulation of diverse clinical scenarios that are not possible in real life. So it helps in 3 areas that for me are important: equity, privacy, and security. Of course, our application should respect all the basic aspects of bioethics, which are autonomy, beneficency, non-maleficency, justice, or related not only with the complex patient, professional, clinician, but also with the society. And arises challenges like data protection and privacy, transparency and explanation, accountability, bias, and 2 things that are also important, which are inequalities of access and the possible dehumanization of care if we are not careful with the design of our systems. So the 3 main challenges are data, first, because we have heterogeneous data, we have images, we have tests, we have signals, and the data is fragmented, is noisy, incomplete, and deeply contextual. The diagnoses are not a ground truth, and they evolve on time, and data reflect historical practices, systemic bias, etc. So we go directly to the second challenge, which is generalization. If we train in one center, perhaps the results are not as accurate in others because we have differences in patient population, in the protocols, in the equipment, etc. And so we have distribution shifts between centers, but also we might have it in the one center that we train due to changes in population, for example, for immigration. So this pops up the problem of the need to audit models and data. And the last challenge is explainability and trust, because clinicians are accountable for their decisions. So the problem here is that we have developed more and more complex systems, AI systems that are more and more accurate, but more difficult to provide. It is more difficult to provide explanations, and this comes with systems that are unlikely to be trusted. And now accuracy alone is not enough. We have regulation in Europe. We have been talking about this since the first publication in 2019 of the ethic guidelines for trustworthy AI, which are the ones that we can see here. And these recommendations are also to be seen in the recommendations of several international organizations like UNESCO or the United Nations. We also have a regulation in Europe, and the health applications is based on risk. The health applications will be on the high risk side, and these will be are not yet fully implemented. We will have it during this year. We have commented more or less all the aspects like human-centered, the human is always in control, privacy and data governance, the equity, non-discrimination, responsibility and accountability, transparency. And I would like also to emphasize the sustainability and social well-being part, because the models have an ecological impact and an impact in society that needs also to be measured. There are specific points that are relevant, and we'll comment later in detail, like privacy, for example, in which we work in both sides, in the legal and ethical side, but also in technical solutions like privacy assessments, federated learning, privacy preserving machine learning, etc. The same thing is going on with bias, discrimination, and prejudice perpetuation, in which we can find possible bias in several applications due to unbalanced data in gender or race, or a non-adequate model that can cause bias in the populations. Another thing that's important is neuro rights. This comes with the increasing amount of wearables that we have and the power of AI to develop profiles from the publications in social media. So we have already some regulation in Spain and also in Europe about these 5 points: mental privacy, free will, personal identity, equitable access, and protection against bias. And finally, we have mentioned accountability, which should be shared, contextual, and distributed between algorithm developer, the organization that has implemented the AI model, and the health professional. So recapitulating challenges, we already mentioned all of this: autonomy, algorithmic biases, accountability. But I would like also to point out the future that we need to rethink, the future of the physician and the doctor-patient relationship, and the role of the physician as a part of the developer team, an interpreter, and a validator of AI. By actions, we have talked about regulatory frameworks and ethics by design. We cannot continue to do ethics as a patch at the end. It needs to be an intrinsic part of the development of the system. We need education and alphabetization in AI, but also interdisciplinary collaboration. The dialogue should be continuous between the engineers, the clinical personnel, legislators, sociologists, psychologists, patients. So we need hybrid teams. And finally, just mention some areas. I'm not going to be extensive on this, but we are working technologically in several points concerning the detection of bias, the machine learning privacy preserving from the beginning, federated and collaborative learning, also to be able to learn from areas in which data is scarce or is unlabeled, on explainability, and other things like responsible evaluation and metrics, generative models, and finally also about this patient-centered and ethical AI that's very relevant increasingly during these last years. And that's all. Thanks.
Thank you so much for your great presentation. We have already several cues or tips for the coming up Q&A. And by the way, notes to our participants here. So if you just join now this webinar, so please feel free to engage with the YouTube comment box. So please leave your questions. You are free to leave our questions and comments, of course, so that we can, after these presentations, we can engage directly with your participation. So we are now moving to our second distinguished guest, Heidi Mertes, and the presentation. So as I briefly presented, Heidi Mertes is Associate Professor of Medical Ethics at Ghent University. Heidi, once more, thank you so much. And please, the floor is yours for your presentation. Thank you.
Thank you, Paulo. Yes, I will also be talking about the challenges of AI in healthcare. So I will overlap a little bit with what has been said, but I think it's not a problem. It will make sure that things stick better with the audience, I hope. I have grouped the ethical concerns. Well, perhaps preliminarily, I should say that, of course, AI has many benefits, because as an ethicist, we're already always talking about the problems or the concerns, but I don't mean to say that there's nothing good that will come out of it, but I think that will become clear in the discussion. But I do want to talk about some concerns that we will need to tackle, and which have already been mentioned by Amparo as well. I've grouped them in a couple of under a couple of umbrellas. So the first one is reliability. So first set of concerns, regards the output that we get from AI. How reliable is it? And then I want to point out a couple of things. One is that oftentimes AI systems are built on probabilities, but they are presented as certainties. So specifically also, well, what you know, for example, with generative AI, when you are working with large language models, oftentimes they present something as if this is like the outcome, but it doesn't really mention that it is a probability, not a certainty. Similar to that, oftentimes we are talking about correlations and not causation. So for example, in genetics, when we are talking about genome-wide association studies, so big data research, you find correlations, but there might not necessarily be an underlying causal factor. And sometimes in AI, this is not easy to distinguish, especially for the people using it. So a simple example, for example, there will probably be, so people that live in the Mediterranean area have less problems with cardiovascular diseases, and there are probably also genetic mutations that are more prevalent in that population, or variations. But does it mean that if I have such a variation, I will have a lower chance of cardiovascular disease if, for example, I live in New York? Probably not, because a lot of that cardiovascular risk is linked to eating habits. So if I consume a lot of olive oil, then I might have those lower risks, but not if I live somewhere else. Okay, and then the next one, also linked to that again, is that statistical significance doesn't mean that there is clinical utility, or that the clinical utility is as high as we would expect. There have been some well, unfortunate but very good examples of this, where you have a system that supposedly predicts an outcome. For example, which patients in hospital will develop sepsis and which will not. But if it is not much better than random chance, then we can't really use it much, because then we still will have to check everyone that also does not come up with an increased risk, and we might be overdiagnosing. I'm jumping over all of this quite fast, but we will have time for Q&A, so I'm sure if there's something is unclear, that we will be able to figure that out. And then, of course, also training data sets are not real-life data, although you can also work with real-life data or real-world data. But oftentimes, an AI algorithm is trained in one particular setting, and then if you deploy it in a different one, you will have to check whether or not it will actually work in your new population. Also, we are working a lot with big data, but having a lot of data doesn't necessarily mean that it's also high-quality data. So I think we also should take that into account, or pay due attention to that data quality is at least as important as data quantity, if not to say more important. And then regarding reliability, I think we're also battling this image that somehow human judgment is subjective and therefore less reliable, and data is objective and therefore very reliable. The data don't always speak for themselves. They always have to be interpreted. Also, algorithms have certain values built in and certain interpretations built in. So we have to take that into account as well. So it's not necessarily the case that because it is data, it is better. And then regarding fairness, this is also something that Amparo already talked about. But sometimes you have bias in your data, which means that you might extend systemic discrimination and stigmatization, for example, that you might already have in a population. For example, if you have a population that has historically never had much contact with healthcare, then you might say, oh, this is a group that doesn't need much healthcare, and your AI system might actually deprioritize these people for care, whereas then, of course, you are contributing to social injustice. Responsibility and accountability is an issue there as well. So the typical question, what if it goes wrong? And what if the doctor has to decide to follow his own judgment or the AI? Whichever choice he or she makes, they might be liable they might be called out for that decision if it turns out to be the wrong one. But what are they supposed to do? And so that's another question that we need answering. And then regarding fairness, one elephant in the room is also the digital divide actually on two fronts. So one is not everybody has equal access to AI, but also there's a big power imbalance also between the companies that have all these health data in hands and that are developing tools for us to use them, and the individual user or the individual citizen that might not have much leverage when they're concerned about how their data is being treated. Which brings us to data harms. So it's concerns there about privacy and confidentiality. These are medical records, so typically very personal data that we don't like to share with our neighbors. So there will need to be guarantees there. You can do a lot of things. So you can aggregate data, anonymize, pseudonymize, but it's, I think, an ongoing, we have to be on watch ongoing for this concern. And I already mentioned the power imbalances, which brings us to my final group related to care. So there are some concerns about the interaction, the human or patient-doctor interaction that we have today. Will it be replaced by less personal interaction? When you ask people, what you value in healthcare, oftentimes it is that the nurse is friendly, that people listen to you, that the doctor, that you can feel that they care for you, that they are concerned for you. An AI algorithm cannot replace, of course, that human care. There are some concerns over de-skilling. What if we outsource many tasks to AI, but then all of a sudden we do have to make a call ourselves? Or if a doctor needs to do that, will they still be able to do so without the AI tool? And then recently, for example, Eric Topol also mentioned that we might actually evolve into a situation where there's not only de-skilling, but actually never skilling. Will our new generation of healthcare providers, will they actually learn all the tricks, the tips and tricks of the profession, or will they rely solely on AI? And how will that impact on healthcare? What will the impact be on a healthcare budget? That is not clear yet either. And then, of course, there is also an environmental impact, which, when you're working in the healthcare setting, should also be something that concerns you, because we know that having a bad environment also brings more people to the clinic. And then very shortly, because I knew that we were also going to talk a bit about health journalism, I wanted to just give one example of this, of the very first point I made, which is how health journalists report on these predictive algorithms. So, for example, there are new AI tools that are set to predict medical events, predict patients' future health conditions, predict how cancer patients will respond to immunotherapy, and even predict how long we will live and when we will die. When people read this, they think that these things are actually, a window into the future and of their personal future, so that it's very individual. But that is not the case. These predictive algorithms are about people that look like you, and if the algorithm says you have an 80% chance of developing lung cancer, it means that if there are 100 people similar to you, 80 of them will develop lung cancer. It doesn't mean that you will develop lung cancer. So I think we should change some things there. So if the headlines would rather be that an AI tool calculates the probability of a medical event, estimates the probability, it predicts how patients may respond, it guesses your life expectancy. I think that would help a lot in how people conceive of AI and what their expectations are, and the extent to which they might be deceived or not by its possibilities. So, but I will keep it at that so that we have enough time for a discussion, which I'm very much looking forward to.
Thank you so much, Heidi. Well, we could take much more than 1 hour to address all these great topics that you brought in. So I will start with some questions, and I will start with Amparo. So from your perspective, currently, without predictions, I would say, what is the most meaningful way that you think AI is currently impacting healthcare? And also, where do you see its greatest untapped potential yet to arise?
Well, I think that at this time, AI is already transforming the interpretation of medical images. So in radiology or pathology, there is an increase of the importance of AI as an assistant. Also on risk stratification, so we can predict in a general way sepsis in a patient, heart attacks, and even some personalization and treatments, mainly on oncology or pharmacogenomics. And on the other hand, we also have the automation of some administrative tasks, triage, for example, in emergency departments, that help us to free clinical time. As potential things for the future, I think that an important thing to do is the combination of all the data that we have, which are heterogeneous and comes from different specialists, even like medical records, genomics, the data from our wearables, and our social data. So we can finally build this One Health holistic predictive models. Perhaps some kind of personalized communication for the patients, always with human doctor supervision to avoid the personalization and the humanization, but with virtual assistants that can communicate with the patient, for example, and solve some of the doubts that arise with the treatment. Can I do this while I have this treatment or I don't? Things like this, which I think could emphasize the help of AI with patients. And then another thing is to try to have more equity, reducing gaps in access to specialists, perhaps through AI tools in rural areas or in areas with resource constraint. Well, that's about it. There are a bunch of different areas that we could pose for the future.
Sure. Heidi, you brought in your presentation topics as a user-centered design, as well as the importance of tackling digital divides, which in themselves have brought in different types of divides. So in your view, what should clinicians and healthcare researchers also play in the design, development, and also validation of AI tools to ensure alignment with, let's call it this way, the tech design tools and the real world clinical needs?
Yeah, thank you for your question. Yeah, I think it is important that there is that people work together, because one of the concerns that I actually didn't address yet, but I think are very prevalent also in the minds of tech developers, is that what they are able to do with technology is not necessarily aligned with where the greatest needs are, and they don't necessarily also know where the greatest needs are. So, for example, one of my students did an interview study on people working on robots to deploy in elderly care homes, and So there are different tasks there that you might want to, we don't have enough hands there to take care of people. But what can they easily do is, or what they have done very well, is make a robot that can talk to people, that can have a conversation about, silly things, but it's nice. People can then talk. But what is much more difficult is, for example, tools to actually provide, let's say less personal care. Take them out of the bed or put them back into the bed, for example. So, but then this image that we have, like, AI will make everything better. It will do all the boring tasks, and then we will be able to do the nice tasks and the rewarding tasks. That's of course not necessarily how it will work. If the technology is very good at doing the interesting tasks and not as good as doing the boring tasks, then those are the ones that will be replaced. Now, of course, oftentimes it will align. So I'm hoping that we can do that maximally, but that requires people in the field to actually tell people on the tech side, like, this is what we need, this is what we want to replace, and this is what we do not want to replace, because this is something that we would like to stay in the hands of actual healthcare providers. So I think it's important that we have that that difference in, or that we don't take it for granted that it will automatically lead us to the best applications if we let the technology steer.
Well, we have a question from the participants. Can I introduce one? So there is a Heidi Rocha that she works in research in medical settings, and she's feeling curious about your opinion on the over-reliance on AI tools for medical and treatment processes. So what these days patients ask AI tools for medical advices, even questions regarding processes and procedures. What is your opinion? How we can make it safe? Of course, use information available, but how can we make it safe? What is your opinion? Heidi Rocha question.
If the question is addressed to me, I will go first, and then Amparo can perhaps add. I think it is one thing. No, I think it is good that people can do their own research, let's say, and be more knowledgeable through the tools. But I think we also have to be careful with all the empowerment rhetoric around that, because it seems like we say, if you have an AI tool, now you can take care of your own health, and that's also how it is marketed. But of course, you need health literacy and you need tech literacy. And many people don't have those or don't have them sufficiently. And I think it's important that they keep looking at it as a tool that can help them and their physician to come to the best solution, rather than this being, let's say, put against their physician. And I hear more and more stories coming of physicians who say, well, we try to explain to a patient that they should not actually have 25 tests done because they have a headache today, but their AI tool told them that they should, and now they're putting pressure on us. And it, of course, puts them in a difficult position, because then they have to actively say, no, I refuse to give you that test, whereas otherwise they would say, no, I don't see any reason to give you that test. So I am a bit afraid that in terms of the cost of healthcare, we might be doing a lot more of treating risks than actually treating severe conditions, and that perhaps the judgment of a physician might not be relied on or not be trusted so much, because there is this other voice that gives a different advice. And I must say, if I would be making such an AI health tool, then of course I also would want to be careful. I don't, if I say, you'll be fine, nothing is wrong, and then the person turns out to have some terrible condition, then I would be liable. So as a designer, it might be important that you are on the safe side, and that you say all the possible things a person can have, including all kinds of terrible illnesses. But of course, that also means that people will be very worried and might not trust their healthcare provider anymore as much.
Paul, back to you.
Thanks. I will actually like to put a question that comes from Heidi's presentation, which has to do, of course, with the AI communication or the mediated effects of AI. But since Heidi presented, I would like to address Amparo's view on this. So what role do you think should both health researchers and health professionals, but of course also health journalists, play as mediators between science, technology, and society?
sorry, I have my audio off. Well, I think that you see, AI sees the data and outputs a pattern, and then it is the clinician or the professional of health who needs to see what the AI have said and put the precise context for that person in particular. So the AI sees the data, the health professional sees the patient, and the journalist sees the society, how this relationship between patients and AI can help or can confuse or whatever the society. And this said in general, I think that Heidi before put a very good example with the kind of things that can happen when perhaps also we are producing these titles or these news in the media without proper revision, and then we arise expectations that are not true. So I think that it's important to have the health professionals involved in the team since the very beginning, because they are the ones who know what's important in health, which are the cases that we need to take into account, how to do it, how to test it, all these kinds of things. So really the teams should be hybrid, because we need all the knowledge from the very beginning, the technical one, but also the knowledge about the field. This was very clear, for example, in the old AI. See, when we have the symbolic AI, in which we need, as knowledge engineers, to talk to the experts and develop these rules. So I think that we are coming to an age in which we need to merge both things, because it's true that we have a lot of data, but it's also true that we need the knowledge. And sometimes, well, not sometimes, all the time, data and information and knowledge is different. And so everyone has a different role in this scenario. Also the people who work on the diffusion of the news.
Thank you so much. We've been just how long the last decade we've been seeing it in different social domains, also of course in healthcare, but I was recalling also the so-called predictive policing as other practice. So Heidi, since you presented here the direct screenshots from the news, so how can or how should risk and uncertainty, which of course it's maybe a challenge when journalists have to write a news piece, so how to deal with uncertainty, which of course is much more easier to say. It's easier to say that the system is predicting the future. So how do we see that the risk and uncertainty can in healthcare particularly can be communicated when using AI-based tools?
Yeah, I think in principle it shouldn't be so difficult, but I think the way many of these tools are built, they create an image of not talking about risks and probabilities, but talking about certainties. But it's not. I mean, it's just a way of changing our language, really. I think if we keep pushing it, if we, for example, don't call them predictive algorithms, but probabilistic algorithms, for example, I think that might already change how we look at them and give us a better view of what it actually does. Also explaining, perhaps to journalists in the first instance, because then they have to explain it to the rest of the world, but how these tools work. I think a very good analogy that is oftentimes made for people who are familiar with Harry Frankfurt's work is that AIs are bullshit machines. So the philosophical academic meaning of bullshit means that you are not concerned with truth. So you generate in the case of AI, you generate an output, but whether this is the truth or not is not really the concern of the AI. The AI just says it. Well, I think about LLMs now specifically. It's just what is the most probable next word in my sentence, and it is correct at predicting what is the most probable next word, but that is not about the truth. That's not about about reality. But I think people don't necessarily understand that. I think they think that AI knows a lot and understands a lot, and that it can then reason and bring it together. But that's not really what it is trying to do. It's just making a prediction of what is most likely to occur. And if we just keep explaining that to people, I hope that they will also interpret results differently. And also, perhaps also important there. Well, I'm not sure if it really relates to your original question, to the risk, but oftentimes also, and I'm thinking now specifically about ChatGPT and those kinds of tools that are now also being turned into health tools. They very much confirm also what somebody wants to hear. So if I'm already concerned, then this tool is very unlikely to say, oh no, but you're wrong, you shouldn't be worried, it's all good. It will say, oh, I understand why you're concerned. Oh, I feel with you. So it will kind of like always confirm what you're feeling, whereas a medical doctor might say, no, you're wrong. you shouldn't be so worried, or we're getting, so I think trying to make clear to people how these things actually work might help us. And what actually also helps, unfortunately, it's stories of when things go wrong. I think oftentimes also in public engagement, if you tell people a story of where there were actually healthcare problems generated because the system did not work well, then oftentimes that helps people understand, like, oh yeah, how does it actually work, and how come this happened? I don't know. Perhaps I deviated a bit from your question. I'm sorry. But
it was great. Paulo, we have a question again from participants. And this one is for Amparo. Amparo, you referred that synthetic data could allow a better identification of social factors that have an impact on health. So the question is related to that. And how do you make sure that synthetic data keeps important differences between the groups, instead of hiding them or repeating the same biases?
That's a relevant question.
Yes, it is.
It's difficult to generate synthetic data with meaning. You must be sure that you are doing the right thing technically. I mean, normally, what you try to do is to create more data so your algorithms can generalize better. But we are not talking about creating data from void. I mean, you have some data, you need to do data augmentation, which is synthetic, assuring that you have certain variables under control. I know certain variables regarding where the patients live, which diseases they have, the number of males and females, and things like that. And then you can test and simulate different circumstances. For example, we have worked in how a disease is disseminated in a population when you yes, when you dictate certain norms and regulation. What happens in the COVID, for example? So you have real data from certain people that you did a survey or something, you have data, real data from that, and then you increase the population and see how they communicate, which effects do these policies that were implemented have, and with that you can model different situations, things that are not possible, of course, in the real life. Or you can augment the data that you have in a certain kind of cancer, for example, and try to use that so your algorithms can generalize better, because most of the models in AI need a lot of data to work properly. If you don't have that amount of data, your conclusions are not as good. So that's one of the things in which a couple of things in which synthetic data is useful or can be useful.
Back to you, Paul.
Thanks, Heidi. very often hear a lot actually about AI literacy, but in this context that brings us here together today. So I would like to hear your thoughts on what do you think that AI literacy in practice for doctors and nurses, what should it mean to every clinician to be able to ask, to verify, and challenge actually also when using AI on a daily basis?
I'm sorry, I forgot to unmute. Yeah, I think we need a lot more education also of physicians, although I think they oftentimes do grasp the limitations, but it could, I guess, be better. But also I think we need to help them be able to interpret. Like, for example, I might be a clinician that has a tool, a predictive algorithm that I want to use. And now I'm saying predictive myself, I mean a probabilistic tool. But I might not know what group it was trained on, for example. So what would be really useful, I think, is for each AI tool that there would be kind of like with a drug when you have a list of information about the drug, where you have a list of information about the tool, like in which patient population was this tested? Was it validated in a situation that is similar to mine? Was it, I am treating an elderly lady now, but do I think it might be valid for her or not? So it would be good if the tool indicates, like, for which patient groups is this, or for which patient groups do we know that this particular tool works or does not work? So that people, you can't expect a physician to all of a sudden become a data scientist and a tech specialist. So I guess they have to help also, give guidance and give information and say, well, we developed it this way, and that's what it means for your clinical practice. That's it. We didn't test it on everyone, or we, just be honest, I guess, about the limitations also about a tool that you put on the market, because you might want to say, oh, it works great in our clinical trial, but yeah, I mean, you have to be careful that your marketing doesn't like hinder your honesty also about its limitations, I guess.
Thanks, Heidi. So I'll also, Amparo, like, because you already mentioned here, so also let's call it omnipresent topic on this topic is, of course, the notion of bias. In particular here in healthcare is, I would say, particularly important, since we are dealing with not just private, but even intimate data. So not assuming that everyone understands how bias relates with data training and that data sets. So could you very briefly, I know it's a challenge, explain briefly how bias enters the pipeline, so it related with data labels, with sampling, and of course, what types of mitigation can we as users or people in healthcare practice use to avoid, of course, to fall into that trap?
Bias is when your model is giving an inadequate output to a certain group of people for some reasons. For example, imagine that we have a system that was trained in a hospital which didn't have a population from outside the country, or something easier. For example, most of the models that we have were tested years ago mainly on male cases, just because it was the common data that we have, more males than females, for example, for heart attacks, because males suffer more heart attacks. So the population treated naturally was unbalanced. So what happens is the algorithm generalized to one of the genders, and it doesn't work as well for the other genders. And this is because we didn't have an adequate balance on the population, and you need to be to detect that in advance, so you can have fair diagnosis for both. But this also happens with bias in race, just because you didn't consider the data set with these different subsets of different races, or you didn't have people from that race before because the immigration, for example, was not strong in that hospital in particular, in the territory, or perhaps not only because of the data, but because the diagnosis, how you conceive your system is also biased towards what you think is normal. I don't have now a health example in my brain, but I remember the case with detecting problems in the roads in Boston. It was an app that you can wear in your phone, and the app was working perfectly, but you need high-tech phone to be able to detect that bumps. And most of the bumps of the city were in areas in which the people doesn't have access to that telephones. So that's a way in which inadvertently you can provocate bias there. And bias is not something that's fixed at a certain time. It's not frozen. As I said, perhaps your hospital didn't have people from certain race or origin, but now you have a lot of immigration in that place, and there your population has changed. So, and your system is not working properly. So the problem is your model needs to be audited continuously in somehow. So to detect, you need to retrain with this new data. So that's another point in which we need also to the help of the clinicians, because they know sometimes when this happens, and can help on retrain or change in the system. And also we need more metrics than the ones we have.
Paulo, we have another question, and I'm going to ask you for now a short answer, because this is the not the last, because the last one will be made by Paulo, but one of the last questions and answers. And this one is quite sensitive. The question is, okay, we often treat data as an objective reflection of reality, but data are created, not simply given, and they reflect choices about what is collected and how it's collected. So could AI therefore reinforce a biased or distorted representation of reality rather than improve it? So this is a good question. Who wants to approach this? Yes, Heidi.
Yeah, I'm willing to comment on that. I like the question a lot, because one of the concerns is, for example, that a lot of these data come from electronic health records. But there you are forced to turn very complicated stories of patients into codes, basically. And those codes are not necessarily aimed at training an algorithm. They are aimed at billing, for example. So and doctors sometimes also try to cheat with the billing, so they might put in the wrong codes, because then the patient will get more reimbursement for a certain procedure. So we seem to think that these data are indeed like objective, and that one is they don't capture everything, so that's they might be objective, but they are not complete. And the other thing is that the way we structure the data is not necessarily made well. It's not. What is best for the patient is not necessarily best for billing, is not necessarily best for training an algorithm. So we have to find like some kind of common ground, and it's not going to be the best for all these different applications. So yeah, very good question.
Thank you, Paul. Last question now.
So, so since we are really reaching the end, so I will ask, a kind of a challenge to both Heidi and Amparo. So to close, in 30 seconds, if you can, each. So what practical recommendations would you give to clinicians or nurses and healthcare managers also watching this webinar? So the hardest question comes in the end. So, so Amparo, if you want to start, so I would of course ask you 30 seconds or so, if you can. Thank you so much for that.
It's a difficult question. I don't know. I think that they have a main role in the artificial intelligence, in how we are going to conceive it in the future. So the field is open to give their ideas and on what's important and how we need to do it.
Heidi?
Yeah, I think my advice would be like embrace it when it is useful, when it improves clinical practice, which it can in many aspects, but don't use it when you don't need to, you know, or when you have concerns, or it's oftentimes people say like AI is like a hammer looking for a nail to hit, and I very often have that idea, like it's very hip, it's very cool to have an AI tool, but it's not necessarily better in terms of giving good quality care. And sometimes it has both benefits and drawbacks, and then I think it is important to keep your eyes open also for the drawbacks, to make sure that you are not, I guess, blinded by the glitter and glam that is sometimes around it, but to also stay aware that, you know, it might be a fancy tool, but is it also what is best for your patient?
Thank you so much, Raquel. Is that you?
Yes, so it's time to wrap up. We are now coming to the end of this webinar, and I would like to sincerely thank everyone who joined us today. And first and foremost, a heartfelt thank you to our invited speakers. You were amazing. You were amazing. And thank you for the generous, insightful contributions you shared with us. Thank you for not only presenting your work and experience, but also particularly for challenging our assumptions and helping us reflect on what AI can deliver in healthcare. To wrap up and to finalize, today's session reminded us that AI in health is not only about innovation and speed, but also about quality, safety, accountability, and trust. We explored opportunities where AI can genuinely add value, but as well, we discussed the key limitations and risks. Thank you again for your time and engagement. I'm going to ask the ISPUP team to take a picture of all before we finalize. Can you please take a picture and confirm?
Yes, just 1 second. I will try to take a picture. Please
Thank you.
smile.
Smile.
Thank you. That's perfect.
Thank you, everyone. It was amazing. Thank you all. Oh, I want to remind everyone for the next meeting, and I was trying to find, sorry, and 19th of March, and the theme, Flushbel, do you have it? Okay. Okay, we'll have our next webinar on the 19th of March. Please put in your agenda, and we are going to talk about communication and how to transform scientific communication in a journalist information. So it will be very useful for all. See you next time. Thank you all.
Thank you for organizing as well. Bye-bye.
Thank you. Thank you for being here.
Thank you.